Good afternoon, everybody. All 3 or 4 of you that elected to come and watch this talk. I'm glad to have you here, and I appreciate the hospital and Tracy and Bobby asking me to give this talk, and Dr. Siegel, who I think thought was the first one that thought it was a good idea. So if it turns out it's not a good idea, he'd be the one you'd talk to. So today we're going to talk about coronavirus and COVID. And you know, about a year ago when all this started, I was certainly no expert in COVID. And over time and we've had more than 500 COVID huddles that I've participated in, and I've looked at probably 700 CT scans and have come to understand some things about the illness and the way we treat it that certainly for nurses would be good for you to understand also, because we doctors walk around and we say, oh, now this person needs this, and you kind of like, okay, whatever, I'll give them that. But it's nice to know kind of why we're doing things at the time that we do them. What's interesting is when we first started taking care of people with coronavirus, we use what we call an escalating approach, which is, you know, give them these medicines until they get kind of sicker and then give them something a little more powerful as they get sicker. We've realized that once people get into the pulmonary phase of COVID, we just give them everything we have and we cross our fingers. And this is a disease unlike any other that we've encountered, and you know that I never thought we would have something like this, you know, like a brand new flu or a swine flu or some type of other just horrible viral infection. But anyway, here we go. I'm just going to go over a couple things, make sure. But, my fly is closed. That's good. Don't sound like a hillbilly. Okay, I'll do that. And don't call anyone a dumbass, I believe it says. So I will do my best to not do that. So anyway, we'll start with the slides, and it's going to be, you're going to think some of this is probably kind of stupid, but we might as well, if you want to know about an illness, it doesn't hurt to start at the beginning. So how did I make the slides go big? Ooh, what did I just do? There we go. All right, thank you, Bobby. So you know all that. So the first slide, you know, it's called SARS-CoV-2 or COVID-19, and here's where those names come from. Severe acute respiratory syndrome, coronavirus 2. Coronavirus 1 was a relative of the MERS virus, which was Middle Eastern respiratory syndrome. And so that's what they officially called it that, and still there's no rhyme or reason. And then COVID-19 comes from simply coronavirus disease 2019. You know, everybody agrees that this virus originated in China, except for the people in China, mainly the government. But they do really think that it somehow mutated when it was in its previous host, which was either a bat or some kind of, you know, flying chipmunk or some kind of crazy animal that's not encountered in the U.S., and mutated and became infectious to humans. So when you look at the coronaviruses, the left is it's a pretend electron micrograph that somebody used Photoshop to put color on, but it does illustrate the reason it was named a coronavirus. Corona can either mean crown or the trumpet-shaped projection at the center of a flower. There's your flower on the left. That's a daffodil. They're really weird-looking flowers, but you can see if you squint, you can kind of make the connection between, you know, that outer rim that is very dense and then a cleared out space and then more dense material on the inside. But that's why they called it a coronavirus, because it looked like it had a crown. And I guess, you know, at the time they named coronaviruses, you know, in the 1920s, the plant guys got to name everything because they owned the microscopes. But anyway, when we look at a graphical representation of COVID, it has what's called the E protein, the S protein, which is the spike protein, which is the important business end of this molecule. The spike protein is what binds to the receptor in human cells the angiotensin converting enzyme 2 receptor. And the receptor on the cell is like, oh, hey, man, I know this guy. We should let him in. And so the receptor activation causes the virus to be an envelope. It gets enveloped inside the cell, and the process is started. So the spike protein is, hope I didn't do that. The spike protein is the most important part of the coronavirus in terms of immunity, but also, you know, the only thing that's inside that virus other than a bunch of salt and some proteins that keep the RNA bound together in a particular state is RNA. And so viruses are just really weird creatures if you study them, and I studied about as much of them as I ever want to. So that's what that is. Now, if you look at the relative size of a coronavirus particle, you may or may not be able to read this, but on the lower left-hand side of the slide, you see that's the Zika virus, which I guess they named it after, you know, Zeke Hillbilly when they discovered it. But it is tiny. It's about maybe 10 micrometers or 10 nanometers in diameter. It's very small. The third one from the left is COVID-19. It's about 0.1 micrometers, so that's 1 × 10 to the -7 meters in size. And it's always good to compare these little things we talk about to the real world. So as you move up to the brown mountain at the end and then the hair, you see there's a dust particle, there's a respiratory droplet, which is how we think COVID is transmitted. Is you can see that it's by volume probably 3 times the size of the COVID molecule, but you can fit a few of those in a respiratory droplet. Then the red blood cell, there's a grain of sand is the silver thing, or a grain of salt is a silver thing, which is about 60 micrometers. 90 micrometers is the fine beach sand, like if you were at Gulf Shores or Destin. And then the hair is, like it says, 180 micrometers, and it shows this hair tapering, which is not what hair really looks like. That's the one I believe the least. But you can see how big it is compared to a human hair. So obviously, you can't touch it and be aware of it. You can't see it, even in large conglomerations of particles, and that's how big, that's the size of it. So if you want to put up the first poll question, which I can't even read, so somebody read it everybody read it, and maybe Tracy, if you or Bobby can read it, or if not, that's okay. Read it to me, though, because I'm not sure what the answer is.
Actively shedding COVID.
Yes, I got it. Thank you. So no, if somebody has got COVID like gangbusters and is sitting in one of the chairs outside the phlebotomy room and they're coughing up a storm in a cloud, and you walk through that, you are likely to get COVID. Is that true or false? So are both the people who came? Ooh, 20. Wow, I bet I know 1 or 2 of them. All right, people are changing answers. No, you're not. I know it's just so. So the answer to this is generally false. You would think that it would just take a little bit of an inoculation to get sick, but it really doesn't. In just everyday passing by of people, you're not likely to get COVID even without a mask on, because it all depends on the next slide. The total virus particle exposure. And so this is really defined as how much filth you stand and breathe for how long, and whether it gets exposed to your mucous membranes in your mouth, the mucous membranes in your eye, and the drainage from your eyes, which is a constant stream of fluid, or into your lungs. And so the real risk is the viral shedding rate, and that is kind of how big of a filth cloud is the person you're speaking to emitting, how far away you are from them, and for how long you're in a distance from them. The biggest issue, or one of the bigger issues, can be how confined is the space you're in. Because if you're sitting outside and talking to somebody with a 5-mile-an-hour wind, even if you're 2 feet from them, very few of those viral particles are going to make it to you to load up your lungs or your mucous membranes of your sinuses or mouth. But what they've found is the distance of about a meter decreases from someone who's shedding, decreases the amount that you get by about 10 times, or the amount you will take in. So they doubled it and made the distance we want to keep apart 2 meters. And then the time that you spend around that person is really one of the biggest risks. The riskiest behavior that we see people use, and the 2 riskiest ones are, I'm riding in a car with somebody with COVID, with the windows rolled up, and somebody, you have the windows up and somebody is just gushing out this virus. And if you drive from Mount Pleasant to Texarkana, you're going to have some inoculated people when they get out of the cars. So the other place is church. I cannot believe how many people, that it's great that so many people go to church, because I go to church, but some people, I think, believe that God has this magic dust he's sprinkling over the church to protect people from getting COVID even without masks. But you can see how, a person can generate their little filth cloud just sitting and talking face to face with another. And if your church is pretty full, that will be a possibility. I know that I was shocked going to a funeral about 3 weeks ago, and it was for a family of a state trooper, and there were 40 troopers. The trooper died. There were 40 troopers there in their dress browns with masks on, every single one of them. And there were probably 300 people at this funeral, and maybe 25 of those people had masks on. And and if somebody got infected with COVID, it would not shock me. And this patient died from COVID, which was an equally sad event. So that's how that is. And I think if you've done this before, you can ask questions, and using the little message board. And if it's a big question, then we can talk about it together. All right, thank you. Make me go away. So the human-to-human transmission, like you see this in all kinds of textbooks, and a bunch of it is probably baloney, especially the bottom part, the fecal-to-oral route. I mean, I don't think I've ever gotten a viral infection from someone's feces because I don't regularly play in poo. Occasionally, I will take a stick and, pick through one of my kids' poops because they swallowed a marble or some crap. But that's not really reasonable. What we think is the main method of transmission is the top. That's aerosol transmission. And like I said, you've got a 1 micrometer coronavirus, which is pretty small. It can get airborne, and especially if you're less than a meter from somebody, and the critical number is about 10 minutes, you're almost guaranteed to get infected, or at least 90% of the time. And so that's why we've made within 30 minutes, you're almost guaranteed to get infected. So we made anything over 20 minutes exposure as a legitimate exposure. And so that's the aerosolized particle. Now, the respiratory droplet was the one that I was referring to also in that how big is everything graph. And so those are the ones, the droplets tend to do, they tend to be big enough to where gravity will pull them down, and they can come straight out of someone's respiratory tract, but they will eventually drop lower and settle out. But that is, the 2 on top are the biggest methods of transmission. Now, all the surface transmission stuff is still kind of drawn into question because, somebody like a droplet on a surface, the only place where I think this is possible is if you have, an exposed eye and you get enough virus in that eye that it sets up in your sinuses and can actually penetrate and get into your blood vessels. I think you can get it from that that route. Now, if you had to look at the number of particles, because people have done experiments about contagious, it's like a contagion equivalent, like how many virus particles does a person have to get? And the literature says it's anywhere from about 1,000 to 50,000. So, we're talking about a lot of particles, and that's why it's a time-based process. The longer you spend in this cloud of coronavirus, the more likely you are to get it. Now let's talk about the contraction of coronavirus. And so does COVID get in through the lungs only? Well, probably not. The most severe form of COVID disease is the pulmonary syndrome, but as we'll see, not everybody, and not even a majority of people, a fairly small minority of people get COVID and get to that level. So just so you'll hear about us talk about the angiotensin converting enzyme 2 receptor. That is what the spike protein binds to on the surface of a human cell. And if you look at where they're present, they are highly present in the lungs, because I'm sure you all remember your biochemistry and physiology from nursing school or Mayan medical school, back where we used candles to light the room, and we drank black coffee and there was no Starbucks. But the angiotensin, I'll do that in just a second. So let me just, the angiotensin converting enzyme takes angiotensinogen to angiotensin, and then that goes to angiotensin 2. And if you put angiotensin 2 into a blood vessel, that blood vessel is fired up for war. It's ready to fight a battle. The blood vessel constricts, the blood actually thickens up a little bit, and it's almost a very strong sympathetic response. So this enzyme, angiotensin converting enzyme 2, is present in a lot of tissues. So one question that a very smart nurse submitted, I know her personally, is your initial viral load exposure a determining factor in how sick you will get? That is a great question. We are not entirely sure, but we do think that the higher viral load leads to a broader disseminated spread within the body, and then that can make you more likely to get the COVID syndrome. Again, we don't know how much it takes, but we do know that the exposures that are traced to very long exposures, like plane rides and train rides, especially in Europe, people who are in confined, non-ventilated compartments together, one person can actually have COVID and not be that sick, but they're in the phase where they're shedding virus, and the people who were COVID naive that were traveling with them, there was a brief report of 4 people traveling. A 16-year-old had COVID and didn't even feel sick, and there were 2 60-year-olds and a 40-year-old in that compartment with him, and they rode about 1,000 miles, which takes a good like 16 hours by train, and the 2 older people died, and the 40-year-old was on the ventilator in Italy for at least a month, and the 16-year-old never got sick at all. Now, he was a younger person, but even somebody who is barely symptomatic or asymptomatic, if they're around the older person or the person with an immune system problem or somebody susceptible, then they can get horribly sick. So if you see so there is a correlation, although some people clearly, as we'll see, and we have seen, deal with this illness a lot better than others. Some people who, we've had 90-year-olds come into the hospital because we were worried about them. They get remdesivir and a couple other medicines, and they go home in 5 days and they're fine. And, we've had 30-year-old patients come into this hospital and end up on the ventilator for 6 weeks. They get a tracheostomy and a peg tube, and it's just amazing how variable that can be. The disease seems to be worse if you take everybody, the severity is worse in men than in women. And, it's probably because it's husbands and wives, and the wife just talks the whole time, and the husband sits there with a blank look on his face, but he still has to keep breathing. So anyway, I'm just totally full of crap right there. But you can understand that women do tend to have a more mild case in general. So as this slide shows, it's present in the lungs, heart, liver, kidney, blood vessels, membranes that line the GI tract, and mucous membranes. Okay, so COVID can enter the body attaching to the ACE, angiotensin converting enzyme 2 receptor, brought inside those cells, and then what happens? And it's not, if you remember viral biology, it's actually, the viruses are pretty clever. They bind to this receptor, they're taken inside the cell, the virus falls apart, the nucleic acid material hijacks hijacks the transcription enzymes from the body, transcribes these genes, processes it, and the body doesn't know any better. The body thinks that it's just some RNA that got transcribed. Well, we better, turn it into protein and do what it says. It goes through the endoplasmic reticulum and Golgi apparatus, and then becomes part of, is put into a vesicle and excreted into the environment. Now, it's showing those little spike proteins on the surface of the infected cell. Now, this is how cell-mediated immunity works. Now, the only way that we eliminate a virus from our system is it either lives in our bloodstream and it can't replicate, and it has kind of a shelf life, a blood life of a certain amount of time. But we find in all of the human cells that what our body does, even when it makes our own cellular components, it takes some of that spike protein and hangs it out there on the cell surface itself. Well, a B cell or a specific antibody or a killer T cell just cruises around in the bloodstream, and it will see that spike protein, and the alarm will sound and say, hey, we don't know this protein, and it will immediately call cells over to destroy the host cell. So that is the only way we recover from a virus that is ripping into our body, is our body recognizes it as foreign, kills the infected cells, and then those cells divide and regenerate. And that's why you can see with the ACE2 receptor, which is at a high concentration in the lungs, gets a lot of cells infected, and you get this process, and your body knows the only way to get rid of this virus is to kill our lung cells. Well, you kill enough of them, and then you got a big problem. But that's the way that cell-mediated immunity works, and we'll talk about how that applies to vaccination. But that's what happens, and it's no big deal. What is COVID trying to accomplish? Like, you don't ever hear about COVID, killing enough people and then being, put on the board of directors of COVID and making this huge salary. Viruses are weird because we know that they serve a purpose in nature. In some of them, take little chunks of one cell's DNA, carry it around, and inject it into a different organism or a different animal. This is actually the biggest part of how drug resistance in bacteria came to pass. That the phage, it's called, which is a thing that goes. It's a virus that attaches to cells, injects bacteria, or injects nucleic acid, sucks the nucleic acid out, and then goes to another bacteria and does the same thing. And that's how the initial penicillin resistance, we think, spread through bacteria, is this virus just passed this gene around enough times, and the cells that were resistant kept multiplying, and the ones who couldn't died, and there we go. We now have drug-resistant bacteria, which we all know is a big problem in our hospitals. So really, what's COVID trying to accomplish? Who knows? Bacteria live with our intestines and on our skin. They basically hitchhike on and inside of us and get fed and can reproduce. And I guess, when you think about what is our job here on Earth, well, it's basically to reproduce and not let humans become extincted. And that is a word. I looked it up. And Google's always right. So if it's in Google, you know it's right. So they're also protected from sunlight and air, which will kill, almost any virus or bacteria quickly. But bacteria, we actually are thought to benefit a little bit from gram-negative bacteria in our gut, digesting some undigestible fibers and liberating some vitamins out of some nutritional components. But there's no clear scientific reason why infecting a human benefits the virus or the human other than growing. It can make billions of copies of itself and then go infect someone or somebody else or an animal or who knows what. So, when you think about the purpose on Earth, viruses are some really clever engineering, but all they really do is infect you, reproduce, and then go to infect someone else. Because just like cancer, one of us gets cancer. If we get a cancer and it reproduces and makes a tumor, and then we die, well, the cancer's dead too. So it's over. And the same is true of COVID. And that's the way we're trying to eliminate it, is not allow it to replicate inside of people. And that's kind of the whole thing about immunity. So the basic biology of a COVID-19 infection, at day 0, you get significantly inoculated. And the time course of your illness is not affected by the amount of virus you're inoculated with. It seems to take the same time course initially, and then there is kind of a breaking off of the pulmonary syndrome. So day 1 or 2 after you're inoculated, the COVID are reproducing, entering more organs in the bloodstream. You are likely infectious, but usually asymptomatic. And that's why wearing a mask is protecting everybody else except you. And that's if you are infected, you are much less likely to aerosolize all this stuff out of your lungs and off your mucous membranes and get other people infected. That is, you have a much lower viral. You can't give somebody as much of a viral load by being close to them. So that's the whole point of masks. Day 3 is usually, if you look at all the symptoms of COVID, loss of taste and smell is found in at least 80% of people. The fever, body aches, malaise, runny nose, and maybe cough are way nonspecific and do not really strongly suggest COVID. It's a good thing that I think there's only one other viral illness that causes a loss of taste and smell. We would have a much more difficult time detecting it, and we're lucky that it's happening on a sensory system in our body that we've noticed. If you go and get the best, cherry pie, which is absolutely the only dessert anyone should ever eat because cakes are nasty. But if I bit into my birthday cherry pie and it just tasted like, pizza from Papa John's, which is like not much, you would be disappointed. So, you're obviously disappointed, but I swear I used to think loss of taste and smell, that's bogus. I've never heard that before in my life. But then when you actually ask people who were just diagnosed, what made you seek attention? And it's the loss of taste and smell and the fever. And of the 5 doctors in this area who've gotten COVID, who I've talked to each one of them, it was taste and smell and fever. One younger one, and then, younger than me, and then 4 older than me. So they're the old people. So even though I'm pretty old, but that fever and loss of taste and smell is really it. And that is kind of the first sign and symptom of coronavirus. So by that time, you're infected. And so when we talk about, giving medications like bamlanivimab, you're counting day 3 of your illness as day 0 of your eligibility for BAM or the Regeneron product, the casirivimab. So day 4 through 8 is usually a gradual improvement of symptoms. Fever, runny nose, and myalgias improve. So day 4 through 8, there's not much going on. Of the people that I followed from the very inception of their illness, what happened is, and it was people who are busy working people, including physicians, they would get to, they get diagnosed on Monday, and then by the day 4 through 8 of their illness, but by day 5, since they've been sick with COVID, they're feeling so much better, and they say, this is bullcrap, this quarantine. I need to go to work because if I don't work, I don't get paid, and I think we all know how that feels. So they're chomping to go back to work, and so one of those physicians, I said, no, you need to wait till at least Wednesday or so. Let's just be safe and be sure. And then on Sunday, I get a call from the doctor about 10 o'clock at night. In a very somber voice, the doctor says, man, I got a fever of 103 and my chest feels tight. And so that is a bad sign, only that they got to get inoculated enough to have go into the pulmonary phase. So 70 to 80% of those who get infected with COVID, they get better and they move on with life. They do not have any evidence of the pulmonary phase or anything to make you think that their lungs are becoming involved. And like I said, that the reason this is important is that the ACE2 receptor is in really high abundance in the lungs. You get enough of that stuff into your lungs and through your bloodstream with what we call viral sepsis, and you can really have a lot of lung tissue start dying. And so that pulmonary phase we'll go over in just a minute. But so in this time frame, before patients feel ill, the monoclonal antibodies, bamlanivimab and casirivimab and imdevimab, that's BAM and the Regeneron product, respectively. You give an infusion of 700 milligrams over 1 hour, and everybody goes to, they move on with their life. The only people I have seen progress to pulmonary disease or pulmonary illness are people who we later realized on CT scan did have some lung involvement and did progress and get the pulmonary syndrome even though they received BAM, because it seems like once you start to get the pulmonary syndrome, it is a whole new ballgame with regard to the expression of the disease as an illness and the things that are helpful to make it go away. Up until that point, it's, basically just supportive care and antipyretics, because the fever can be quite impressive. I've seen almost 105 in 10 and 11-year-olds, but nothing like that. But still 103 when you're an old person like me at 54 can make you miserable. So you give these monoclonal antibodies over an hour. You watch them for an hour. The only side effect that is reported is nausea. There's a bunch of other things that can happen, but in people anywhere from 17 to I think 86 that have gotten these, nausea has been the problem, and no one's even thrown up. They just said, I kind of feel crappy. Now, if you receive these drugs, the closer the administration is to the symptom onset, the better the chance of a benign course with a quick recovery. So what does that mean? That means, we're talking about, Suzanne asked the question about the initial viral load exposure. You're going to carry probably that same degree of illness into your bloodstream. And these are antibodies to that spike protein, the S protein. So the S protein binds to the receptor, okay? It binds to the receptor on the ACE2 receptor because it's rolling through blood vessels, and it sticks to that receptor, and then the process starts. The cell is like, hey, we got a customer. Oh, we know that dude. Let him come in. And you got a problem based on that right there. But if you cover the spike protein on the COVID spike, and it's covered with an antibody, it keeps rolling past all those ACE2 receptors, and eventually, they roll around long enough and they just get broken up and fall apart. And so by giving BAM and the Regeneron product, which is kind of their short nicknames, you will see a significant lowering in the viral load and a much lower degree of illness. And so that, kind of brings us closer to the pulmonary illness, which is when you have, when the phase where people are kind of getting better, the virus is either getting eliminated or it's rising in concentration. And that is when people get into trouble, is as it rises, it then gets into the lungs, infects more pneumocytes, they're called, with the ACE2 receptor, binds to that, and then things can get serious. So if you look at this slide, 70 to 80% of people get infected and move on with life, and then things begin to get real for the remaining 20%. And this is not a little thing. This is where, and it kind of sucks as a doctor, where you see someone in the office and you say, hey, well, you got COVID. Yeah, you're diabetic and you're 60 and you're kind of heavy like me, but this should clear up in 5 or 6 days. What do you tell them? You say, there's a 20% chance you get really sick and maybe die from this, which is very true if they convert to the pulmonary syndrome. People who are, the biggest things are being diabetic, and after that it's being obese. And really, there's a cutoff of, a BMI of 40, which defines morbid obesity, where once that cascade starts, for some reason in those people, it's really hard to stop. And then a diabetic obese person is tough. We had one on rehab recently that had been on the ventilator for a month on the ventilator and then trached and got a peg tube and weaned off of that over the course of the next month, came to rehab and went home doing great. But he lost 2 months and 2 weeks off of his life, where he was sedated for the bigger part of it, and he couldn't remember any of that. But he had a BMI of 50 and was diabetic, and it was just a rough ride for him. But we're grateful that some people do even that well. So there's another issue that on day 9 through 11, even though BAM and the Regeneron antibody treatment are approved up to 10 days, well, day 9 through 11 is when you see the fever return, chest tightness, GI symptoms, cough, dyspnea, mild hypoxia. The biggest one seems to be chest tightness and the sensation that they're not able to take a deep breath. Almost 100% of people report that. Fever can happen, but is not that common. Patients who present with GI symptoms, even though it's they still have some degree of the pulmonary symptoms, if somebody comes with primarily GI symptoms, they actually do a lot better and they get well fairly quickly. It's just the people who have the pulmonary symptoms. If you have severe pulmonary symptoms and severe GI symptoms, your mortality can be very high. And the hard thing here is this is where I've had to call Dr. Yates and Tyler, and I have insisted people get CT scans on more than one occasion from the ER and even from a doctor's office, because the monoclonals are not effective and may be harmful at that stage when someone's is already progressed to the pulmonary manifestations of the disease. And it's usually, they feel horrible, they're feeling better, and then they get that fever. And, all you can tell patients is, you're doing good. The call center that Titus set up has probably saved the most lives of any intervention, in that people get calls, say, hey, how do you feel? And if somebody says, well, my chest is tight and I had a fever of 103 and I just can't clear this cough, then they're usually directed to the ER, to their doctor's office, and we make sure that they are medicated properly. It looks like in the early stages of the pulmonary syndrome, the medicines ribavirin, dexamethasone, azithromycin, and anticoagulation can prevent worsening and quicken healing of this syndrome. But I'll show you on CT scan images what it looks like as you go through this process. So this monoclonal thing is tough. That's why, we talk about global testing, just have everybody tested, and they're going to be starting to do that at schools soon. But you'd almost like to see somebody where an older population generally worked, because if you have an older person with all the risk factors who's, diabetic and big and, in generally poor health, you test them even before they positive, and you give them BAM, they can have an almost, uneventful course. And that really saves a life, because it tends to be those people with those biggest risk factors. And, one risk factor is is, it's a hard thing to understand, is people of Hispanic and Latin American heritage as well as Native Americans. They tend to get much more ill more rapidly, and that has to do with this thing we call cytokine storm, which we'll talk about in just a second. So you have the rapid worsening, then pulmonary collapse seems to occur mainly due to cytokine storm. So this drawing, I stole most of these figures, but you can see this is not necessarily what I believe is true, where if you look on the left side, there's the pretend sick person, the ghost drawing. They cough out all this stuff. There's a low virus titer, and they're saying low titer. If you look at the top line, if a low virus titer, I think it's true when you look at the amount of virus in the bloodstream at the day 4 through 9. If it's low, you have a mild degree of inflammation, you have a normal immune response, and follow it to the right, you get green, which is the color of recovery and St. Patrick's Day. But somehow you're recovered and you're happy. If you look at, you go down the bottom row, which is a high viral titer, you get severe inflammation and what we call a cytokine storm. And it's an event that is like a process that begets itself. All of those cytokines listed in the very middle, interleukin 6, interleukin 10, tumor necrosis factor, the Rantes system, all these things, if you measure the bloodstream of somebody in a cytokine storm, those levels are all really high, but we don't know what any of that means. One thing that is interesting, so this storm is the storm. People who recover from COVID and are feeling pretty good, they manage to get past this storm. In plasma, you have antibodies to COVID, but you also have natural cytokine suppressors that we may not even know what they are that can lessen this cytokine storm, because ultimately what happens, the cytokines produce inflammation. The inflammation leads to hypersensitivity of the vascular endothelial bed, primarily in the lungs, and that vascular epithelial bed breaks down, and the blood vessels that go to the lungs begin to clog up and block off. Now, it's not like a pulmonary embolus, but it is like, and an embolus comes from somewhere, a thrombus is made right at the site where it stays, and so you get microthrombi that are innumerable. And if you cut somebody open who's got the horrible, COVID lung syndrome and take a chunk of their lung, put it under microscope, you see blood clots everywhere. And so we know that people who are starting to have the pulmonary syndrome and the cytokine storm, if you fully anticoagulate them, it is much more difficult for those inflamed blood vessels to form clots. And there's another medicine we use, and steroids do this too, but one called Actemra, which is an interleukin 6 antagonist, is somehow important, and at least a statistically significant number of people who are given Actemra seem to recover better. And so one of the approaches to treating this medicine is giving these anti-cytokine medicines, and then the third leg is giving antiviral medicines. And the thing that's kind of sad is we know they kind of work. We're not exactly sure how, but you can imagine, the roads are bad today. Driving to work, there were semis piled into each other and spread all over the highway. Well, how did this all start? Well, I don't know. What do we do to make it go away? Well, we're not really sure. And as your lungs go through the healing process from the pulmonary syndrome, we're not really even sure how did it get this way and how do we get it better? But we have found ways to block the progression from not really bad illness to really bad illness, or really to prevent being really sick and being dead. Okay, so this is why a CT scan can be important. So this is mild pulmonary disease. This is a CT scan of someone's chest, And if you imagine when you look at the CT scan, they are being cut into slices and they're lying on the gantry and you're looking up at their body. So if the vertebrae are in the back and the chest is forward, there's a big R on this one to tell you what the right side is. But you can see in the right side of the lung and the left side of the lung, there are these little wispy areas which we think are edema that results from the initial thrombi that form within the lung capillaries themselves. And so these start to interfere with gas exchange. And that's important because, you got to get CO2 out and get O2 in. And it seems that it's amazing that you'll see this disastrous CT scan at the end, and they still have a normal blood pH until the other organs fail, and CO2 is normal, but oxygen levels are just unbelievably low. And that's because if you get carbon dioxide, what dissolves better into a liquid, carbon dioxide or oxygen? Well, it's carbon dioxide because you can make things called carbonated drinks. And so that CO2 can travel through fluid. It can get out of your bloodstream and into your lungs and exhaled very easily. But getting oxygen in is the problem with this disease. Here's another case of kind of a little bit later mild disease. You can see that stuff is becoming more fluffy and there are patchworks. And we always talk about proning patients. You can see in general that the illness severity is more in, say, if you're laying down, gravity pulls more fluid down to the lower parts of your lungs, and that's where you see the infiltrates. Now, this is somebody who that came through the ER, and we saw the patient. He wasn't real big. He was Hispanic. I believe he was in his early 50s. And he has almost complete involvement of the lungs at that level, the level of his ventricles, the mid cardiac level. But you can see how he's got that light colored stuff everywhere. We talked about how we used to accelerate therapy. We admitted this guy, we gave him maximum doses of everything from the minute he hit the door. And he did go on the ventilator, but he weaned off the ventilator and eventually went to an LTAC. But when I see a scan like this, even though it's early, I am really afraid because once you start developing these early lesions, they progress. And I'll show you what they progress to. So this is moderate disease. You can see that things are really getting socked in. The clear regions that you see are areas of lung tissue that have been broken down, and they're almost like blebs, like you hear about in COPD. They're areas where the circulation is gone and the air exchange is not very useful. And you can see that is heavy involvement in the left and right side. This one is kind of the same way. You can see how those infiltrates are becoming more solid. If you look on the upper left-hand part of the screen, or the right middle lobe of the lung, just to the right of the cardiac border, you can see those big airways that just have that thick infiltrate right up against their edges. And you can tell that it's probably hard to get oxygen in and out of that airway. And so what you see is a lot more water moving into the lungs, and you get worsening oxygenation. So this is severe disease. You can see in the left lung on the right side of your slide, you see a bunch of destroyed lung tissue with those big black blebs, which is where there's no blood or probably meaningful air exchange. The hilum on that left side, which is where the blood vessels and the airways come out and spread to the lungs, is really densely socked in. On the right, you see, or on the right side of the person's right lobe, toward the front or the anterior side, there's involvement clear up there, and there's another big bleb right next to the pericardium and the aorta where it's coming up and out of the heart. But you can see that looks pretty bad. That right there is the people who are in the process of trying to die, and that's because their lungs are full of fluid. That's all there is, fluid and immune cells and debris and crap, and your body has got to be able to get in there and try and clean that up. These are the people that end up going to LTAC because, it's just like cleaning up a pitcher of sweet tea from your kitchen is spilled on the floor. A pitcher, we can do that, and it'll take probably, it'll take a couple hours if I'm doing it because I won't even want to start doing it. I'll just hope somebody else slips and falls and cleans it up. But it only takes you about 10 minutes. You get a mop, you clean it up. You spill 2 50-gallon drums of sweet tea in your kitchen with the doors closed. That is going to take a long time to clean up. And it's a very simple concept, but once you get to this level of lung involvement, and they're the ones who have almost whited out chest x-rays, it's going to be a long haul. Like, look at that. I mean, there's some lungs there, and you can see where some fluid, like some oxygen's getting in and out. But man, these people are in a bad way. And by this time, they're getting everything we have, and we're also praying about it. This is one part of medicine that's been so frustrating for nurses and doctors, but we're just, kind of like, there is nothing else we can do, and that's why they do ECMO, extracorporeal membrane oxygenation. They take the blood out of the bloodstream, run it through membranes like dialysis, where they take out nitrogenated waste and adjust the pH when your kidneys are dead. What ECMO does is it oxygenates the blood and gets the CO2 off and puts it back into the arterial system so your body doesn't die, because, your lungs are clearly trying to die in this process. But if you can keep the other organs working, this process will clear up. But it can take as long as a couple months, even longer. But we've seen people come from this level of illness to recovered completely, and they're just normal walking around people now. But this disease is horrible. So the treatment for a patient with serious COVID-19 who's hospitalized: oxygen, azithromycin, ribavirin, an antiviral, anticoagulation with Eliquis or Lovenox, steroids, which I left off of there, remdesivir, which we take when you get sicker. We take away ribavirin, give remdesivir. It blocks the RNA of the virus from being transcribed or turned into messenger RNA within the cell that sucked it in. And then we find that high immunoglobulin content plasma for COVID antibodies really helps people. Low doesn't help quite so much. The crappy thing is, for the plasma that we can get from the blood bank, they test to see which is high and which is low, but they just send it to you. They don't tell you which it is, and you can't request high. So I don't know what to do with that. So, you get high immunoglobulin content, may help a little more. Low immunoglobulin content. Then people who are really sick will get convalescent plasma, Actemra, and there is, all these people are taking ivermectin, and when they've studied it, the studies have been sloppy and done by people who weren't very scientifically minded. So we can't really tell if ivermectin helps. I do think it helps in the early stages of the disease. There's also a study where they use colchicine, which is one of the oldest school gout drugs that's available. And early treatment with colchicine for 5 days prevented the majority of patients who had concern, were high risk for turning to a pulmonary syndrome, and even very high-risk patients. It really dropped the number that ended up getting a pulmonary syndrome. So they were given all the same medicines, and they were matched for about the same degree of illness, and they were given the colchicine, and it was a third of the patients who got colchicine progressed to the severe form of pulmonary COVID, whereas 2/3 or even more of that made that worse. All right, there's a new one. I may have missed this since I came in late. There's a question. But why are people getting sicker later after seeming to recover and ending up on a ventilator? We've been referring to it as a post-COVID lung syndrome. And that's a good question, Nikki. I didn't really cover that, but we do see people who look like they get through the initial, the initial slaughtering, that is the initial COVID decline with pulmonary syndrome, but something else seems to happen that makes things get worse again. We've tried different things, and I thought we were onto a good pattern of just really cranking up steroids when they start to taper off a little bit, but we're not really sure. Dr. Downey sent us all an article today that just addresses this issue. There's another monoclonal antibody, totally different from BAM, that may help prevention of going to a post-COVID lung syndrome. So, you know, I didn't get a chance. We just have a few minutes left. I didn't talk a whole lot about vaccination. I'm happy to answer questions. I will tell you that the last, put up the last question, I think, the poll question. Or no, the third one. What's the third one? I don't even know what it says. Is that the third one? No. Put up the third one because it'll tell us a lot. Can you read me the first part? Sorry.
Vaccination, if successful, makes a person's mucous membranes and bloodstream completely protected from COVID.
Yes. Give me an answer to that. Which is on the bottom? No or yes?
False is on the bottom.
False. Okay. Is anybody here? Is anybody left?
9 of 27.
Hey, all right. So false is absolutely correct. When you are vaccinated for COVID and you get inoculated, COVID gets in your bloodstream and COVID gets in your your mucous membranes. You get COVID, but you don't get sick because it's like you're carrying around your own monoclonal antibody. It's a polyclonal antibody set up to fight that infection, get it to go away early, and it can go away so quickly that you don't even get a fever, you don't get any symptoms at all. And that's why when people say, was the vaccine effective? Well, it didn't prevent everybody from getting COVID, but I can promise if you get vaccinated and you get COVID, you're going to be a lot less physically ill than you would be otherwise. So that's that. Another question, are any comments on long effects post-COVID? You know, we have people who had the worst form of the disease, especially with pulmonary disease. I think there will be some permanent long-term disability related to this, but I've been amazed. There have been some people, one of them works at the hospital, was incredibly ill and is now in, you know, even more active than prior to getting COVID. And he was, this patient, it was a boy. He was really sick, but I'm just so glad that he's done so well. Other people who were a bit older didn't do so well. The one bothersome symptom, it seems like 20% of people who lose their sense of smell and taste don't get it back, at least after a year of having it. Most people do, but some people, I think some people get some of it back, but they don't really feel like it came back. I don't know what you could make of that or what you would not make of that. Well, I'm sorry I dominated this class, but I hope people found it useful and they learned something about how COVID really works and why we do the things we do. And to me, that was the goal of this talk. So I'd like to thank everybody for attending and watching. Are we on?